I'd like to introduce the first speaker, Dr. Yutaka Saito from Japan. As you all of you know, that he's a key opinion leader of the chronic neoplasia for the diagnosing or therapeutic strategy in chronic involvement. So I please the burden to the Dr. Yutaka Saito, please.
Thank you very much, Professor Ogata, for your kind introduction. It is my great honor to be here. Now we are going to collaborate with Professor Pradeep for making the characterization AI wise vision between NEC, NCCH, and Portsmouth Hospital, and already agreed with MOU between three institutions. So let's move on to my presentations.
It is my great honor and pleasure to be here. Thank you, Professor Hassan and Professor Ogata for chairing this session, and appreciate for NEC for giving this opportunity. No COI for this presentation. First of all, image enhanced endoscopy is essential for colonoscopies. NBI has been developed at NCCH in collaboration with Olympus. Our big boss, Professor Yoshida and Tajiri, led this project, and our colleague conducted phase 1 trial. Professor Inoue also developed IPCL diagnosis for esophageal cancer. First, tumor detection is the first step and the most important for colonoscopies. As shown, Corey et al. Reported that 1% increase in ADR resulted in a 3% decrease in the risk of interval cancer and a 5% decrease in the risk of fatal interval colorectal cancer. Next topic is AI. AI will help our ADR increase. This movie shows our real-time polyp detection using our AI system collaborated with NEC. When AI detects a polyp, it alerts us with sound and images like this. This figure shows the AUC between AI and endoscopist. Fortunately or unfortunately, diagnostic accuracy and time for polyp detection by AI was superior to any endoscopist except me. I was not involved in this analysis. So, how is the difference of diagnostic yield between endoscopy vendor? It is really important deep learning for various vendors, not only one company, but also Olympus, Fujifilm, Pentax, etc. Deep learning for flat LSTs is more important. We intensively trained our AI for LST non-granular type referred to our outpatient clinic for ESD procedures. After intensive training for flat LSTs, the sensitivity improved 3.6% for these flat LSTs. 0 to C lesion, it is really difficult to detect even by an expert. Our AI could detect this kind of small depressed type tumor effectively in white light, LCI, BLI, and chromoscopy due to the intensive deep learning of these lesions. This table is a summary of AI for polyp detections. Misawa et al. And Dr. Yamada at our NCCH papers are from Japanese team. After polyp detection, the next step is characterizations. Pit pattern diagnosis proposed by Professor Kudo is clinically useful for polyp characterization and the prediction of histology. Our multi-center RCT using a web-based endoscopic pictures PIT pattern using CV stain was superior to magnified NBI for cancer depth diagnosis. This is important, therefore, genet type 2B need further CV stain for an accurate histology prediction, and there is some risk of SM deep invasive cancer. Therefore, AI is also highly expected for polyp characterization and cancer depth diagnosis. How did the Fuji AI developed? Deep learning for white light, LCI, and BLA image, including chromoscopies. The accuracy of CAD-eye was comparable to that of an expert physician. Non-expert physicians assisted by CAD-eye also showed the same level of accuracy as expert physicians. Our NCCH and NEC is also going to develop a new system to diagnose polyp histology. A total number of the training, validation, and test images, including still images and videos, are listed here. We provided the results of the verification using still images in the table. In terms of sensitivity, we achieved a high sensitivity of 75% to 80% for all classes. In terms of specificity, we achieved a specificity close to 100% for all cases. The inference time per image was 16 milliseconds. Next, the sensitivity for each observation method. The sensitivity increased step by step from white light to image-enhanced endoscopy and chromoscopy as shown. The data is consistent with our daily clinical practice. Verification using videos. The result of the inference for each frame are shown in the table. You can see that the sensitivity and specificity about 10% lower than the cases using still images. We will show you a demonstration video using the qualitative diagnostic model we created. First, were typical serrated lesions. You can see that it was properly diagnosed as serrated lesions. Secondly, a typical adenoma that is also properly diagnosed. And typical adenocarcinoma 1P lesions that is also answered correctly. Now, this table, again, the summary of AI for polyp characterizations. Many papers from all over the world, including our Japanese studies and also from Western countries. Final topic is future AI. Recent review article by Cesar et al. We are good friends. This is another recent review article by Cesare and Pradeep, published in Digestive Endoscopy. Table 1 shows the study in which training data from deep learning trained with at least 100 regions. Validation data focusing only on flat regions. Cesare's sensitivity for flat region was 99.2% and higher than that of ours, 92.9%. But the data for deep learning and validation study were different between two studies. So in the future, I think it will be really necessary to prepare an appropriate data set for this kind of validation study. Research questions were listed here. All of these questions are really clinically important, and we are so happy to collaborate with Cesare and Pradeep for these clinical questions in the near future. This is a slide of Japan Pathology AI Diagnosis Project, and AI will play a most important role in the diagnosis of CRC and the prediction of metastasis and recurrences. Future AI plan will be a multimodality AI to predict cancer metastasis and patient prognosis. There will be lots of hurdle to achieve this project, but this is our dream. Now, Japanese young endoscopists learn IEE diagnosis from these textbooks, supervised Professor Tajiri and Professor Inoue. Is this learning no longer necessary? The answer is no. It is still necessary. All responsibility for final diagnosis still fall on us, endoscopists. So we need to keep learning IEE even after AI technology development. Thank you very much for your kind attention.
Thank you very much for Dr. Saito.
Yeah, thanks so much, Yutaka, because for us as European endoscopists, to have the Japanese expertise in flat lesion in one box that we can keep in our endoscopy room, it is as if I have you in my room when I do every colonoscopy. So it's fascinating. Okay, time now to move to a field that is fascinating from the side of artificial intelligence, that is IBD. And we are so lucky to have Professor Ogata, who is a world